My name is Dr. Siamak Abai, and I'm here to present a very nice streamlined approach to implant dentistry, which is actually combining some of our conceptual understandings of implant dentistry with some of the digital approaches that we're starting to use. They've actually been used quite a bit in the past, but because of a lot of competition in the market with intraoral scanners, cone beam CT scanners, and the combination of different technology that you can put together, it's driven the prices down just a bit so that the dentist can utilize this kind of information to fabricate restorations, fabricate temporary restorations, even before the implant is placed. So the title of this presentation is Delivery of Immediate Final Restorations at the Time of Implant Surgery. And it's a comprehensive digital approach to implant dentistry. I want to stress that it is the delivery of immediate final restorations. So having all the information, we can fabricate these final restorations even before the surgery has begun. So I'm a prosthodontist, and I practice implant, reconstructive, and aesthetic dentistry in Irvine, California. I'm also the director of clinical research and development in gIDE Dental Laboratories, and that's in Newport Beach, California. So before I get started, I want to give credit where credit is due. And obviously, this is a team approach, so there are a few people that I want to thank that have helped me accomplish some of these cases, which I'll go through. The first person is Zach Dalmau. He's the project manager in research and development. I also have Mike Nguyen as a colleague, and he is a computer scientist. And Tim Arthur is a certified dental technician. So with the help of these gentlemen, I'm able to accomplish what I'm here to present for this presentation. So what we're faced with when we're doing this type of dentistry is whether we're able to combine digital dentistry, taking an intraoral scan, and also combine cone beam CT technology under one software to be able to put everything together and do a treatment plan in order to fabricate our restorations. And what we're trying to achieve is going from the first appointment with the patient having no teeth in the lateral incisors in this situation, to the second appointment where we place the implants and deliver the final restoration. So the conceptual challenge is the clinician's ability to combine their knowledge, their clinical knowledge, in achieving such a task. And I'll get to that in just a little bit, but just to touch up on it, obviously we need to know the implant placement, implant angulation, mesiodistal distance between the implant and the natural teeth, and so on and so forth. We also need an understanding of some computer technology to be able to achieve this. And the technological considerations are being able to merge the different data. So intraoral scan data, which is recording the surface topography of what the patient presents with, is a very detailed data that we need in order to create a guide or even do a diagnostic wax-up for the patient digitally. The cone beam CT scan gives us very detailed type of material based on the patient's bone, bone quality, bone quantity. However, the surface topography is not going to be what we would like in terms of resolution to treatment plan a surgical guide, for example. So what we have now is technology that we can merge the two data types, the intraoral scan being an STL file, which stands for stereolithography or standard tessellation language. Essentially many tiny triangles that are put together at a very small microscopic level that give us a very high resolution for the surface topography of the anatomy of the patient. And the data that we get from the cone beam CT scan is DICOM data, digital communication of medicine. is the type of file that gives us the bone quality and quantity, and there are many softwares now out in the market where you can combine these two data and do the treatment planning for implant placement, for the type of restoration that you would want to receive, and also for the surgical guide. And essentially, we are top-heavy in terms of treatment planning, and once the treatment plan is completed, the patient gets the benefit of a streamlined approach and delivery of the implant and the temporary abutment or a custom final abutment or even a final crown at the time of the implant surgery. So there are a lot of biological considerations, and I don't want to go into a lot of details, but because of a lot of work of our colleagues in the periodontics and prosthodontics field and even oral surgery, right now we have a very good understanding of how far away an implant needs to be from the tooth on either side, on the adjacent sides of the implant, and how far away we need the implants, if we're placing two right next to each other, to be in order to create the papilla. And this is very important, obviously, in the aesthetic zone. So a third concept is buccolingually, how far we need the implant and how much tissue and bone support we need to the buccal or to the facial of the implant in order to create the papilla. So all these concepts really need to be combined at the time of treatment planning in order to achieve a successful outcome in this situation for the implant placement and delivery final restorations. So one of the advantages of this technique is that it's a prosthodontic driven implant placement. That means that we need to imagine where we want the final restoration to be. We can treatment plan whether we want to have a screw retained, which ideally would be beneficial to get rid of the junction between the final crown and a custom abutment, and reduce the risk of having cement at that junction within the tissue, which could cause eventually cause bone loss. So we need to have that concept down, and that way we can go from the actual placement of the implant and the location of the implant and conceptualize it. And once we have that conceptualized, we can transfer that information to a digital treatment planning software, and we can place the implants at the correct position. And with the help of our custom abutments, we can help guide the tissue into the proper location and have the benefit of delivery of final restorations at the time of surgery, or even temporary restorations that are continuous with the tissue and help guide the tissue to where we want them to go. And there are a lot of advantages. Obviously, one of the advantages for the patient is that there's reduced clinical time and reduced visits. The patient comes in at the first visit for the clinician to collect all the information. Again, the intraoral scan, the cone beam CT data, even the shade of the restoration. And the second visit, the patient comes in for the implant placement and for the delivery of the final restoration. Another advantage is the accuracy of guided surgery, and I think we've gone far enough where we know that we can place the implant fairly accurately with guided surgery and be able to predict exactly where those implants are going to go because of the sleeves of the implant guide. So we know the location of the implants before we actually do the implant surgery. And another advantage among many is the advantages of having CAD/CAM restorations. Essentially, using the data that we collect from the patient, we can send a file to a CAD/CAM milling machine and have that machine mill out the final restoration before the appointment. So coming around to the disadvantages, obviously one of the main disadvantages that I see as a prosthodontist is reduced clinical time and visits. So going back to one of the advantages was reduced visit and time with the patient. However, that could be a disadvantage because I think everybody's in a hurry now to deliver everything quickly in 1 or 2 visits, and a lot can be missed between those 2 or 3 visits that you take to deliver these restorations. So having patient rapport, spending time with your patient, we're in the healthcare field after all, I think that's very, very important to understand that. Another disadvantage, and part of the reason why I have this picture in this slide, is that although guided surgery can be very accurate, there are a lot of inherent built-in inaccuracies in guided surgery. One of the examples is having a guided sleeve and an implant mount, and the junction between the sleeve and the implant mount can range from 0.2 to 0.5 millimeters in order for the implant mount to fit inside of the implant sleeve, which I will point out in some of the clinical cases that I have videos of. And a third disadvantage for many clinicians is a lot of the specialties, for example, prosthodontics or aesthetic dentists would like the layering of porcelain on top of a zirconia core or a coping. And one of the disadvantages of having CAD/CAM dentistry and a milling machine with only one material is that you don't get that same depth of the reflective properties of porcelain that you do with some of the other materials that are out there. So that has to be taken into consideration and built in to the treatment plan at the time. So I want to finish with this last slide again with the title of the topic for today is delivery of immediate final restorations at the time of implant surgery, which is a comprehensive digital approach to implant dentistry, a completely digital approach without utilizing anything analog that we would normally do in the clinic, in the operatory, and also in the laboratory. I'm also leaving you with my contact information, so please feel free to contact me at any time to discuss the cases that I've presented, and I'm very open to that. So thank you, and I'm looking forward to actually hearing from you. Thanks.
For more education programs, visit the GIDE Institute at www.guidedental.com.